all the way. Should get that tattooed. Yeah, you can't see it now, can you? Defeated the purpose. I've sent you an email anyway. Check your emails. If you've got an email from me that's saying you cannot attend the prac, it's because you either haven't quite yet clicked I agree or you haven't done any of it. If you have, don't stress, you can come, but you need to come and see me beforehand. Right, so today we're looking at inflammation. I've decided to make it really authentic and got the inflamed voice going on. I only got my voice back about 12 hours ago and now I've got 4 hours of teaching, so yay. Gee, if I do this for inflammation, God knows what I'm going to do for neoplasia. But anyway, that's some dark humour, that is. That's explain. Pick that up. Oh, we're back in. We're back in. Yeah, okay. We can turn you down again now. Fucking nightmare. Let's cut out again. No, it's all right. I'll leave it alone. Explain the three major and interrelated components of acute inflammation, and I want you to be able to describe the histopathological findings and correlate that with what we see under the microscope for the case studies. So if you've printed off PDF for the next 2 weeks, you flick to the back, you'll see that there are some case studies there. Those case studies correlate exactly with what we're going to see down the microscope next week. So those case studies are also mirrored in your prac book. So finally we have some coherency through this unit. Not that it wasn't there before. Romy, you're the best. Define inflammation. Definition of inflammation. It's non-specific, but it's a predictable response of living tissue or to a... What? Let's try that again. It's a non-specific but predictable response of living tissue or the response of the entire body to injury. Now, obviously, it's very rarely an entire body response. The important thing to remember with inflammation is it is a normal response of the body's attempt to return to equilibrium. Okay? It's a coordinated reaction, so there are pathways in place that limit it from getting out of hand. It's not to say it can't, but it is coordinated, it is mediated. It involves nerves, vessels, blood cells, and chemical mediators, which we'll look at in more detail. Basically, its job is to contain the damaging agent and mop it up and repair, in a nutshell. So the cardinal signs are as follows. We've got heat and redness. What? What am I missing? Okay, I don't know. Heat and redness, these are caused by increased vascular permeability at the site of injury. So we see increased blood there, and we see a decrease in the blood flow, as in the speed of the blood moving through that site. So that results in heat and redness. We have swelling. This is because of protein-rich fluids leaking out of these permeable blood vessels into the site as well. Pain, obviously, it's a site of injury. Do I need to go any further? Loss of function. So you think of rheumatoid arthritis, it's a type of chronic inflammation. You've got impaired movement of the joint. If you've got an inflammation at the back of the optic nerve, it can actually make you go blind temporarily. So there are impaired functions outside of the site of injury as well, implied within inflammation. In terms of causes of inflammation, it's quite a varied topic, but generally most inflammatory responses are a result of an infection. So this will be a virus, a parasite, fungi, bacteria. Hypersensitivity reactions, these sorts come under two. One is endogenous, so we're talking about autoimmune reactions. These can be quite severe. Or it could be exogenous, so that's your hay fever or your allergens to gluten. Physical agents, chemicals, hand in hand. So physical causes of inflammation would be, you're out at a nightclub and someone slashes you up a bit. Chemical could be something that it's going to give me the shits. It seems to work. Chemical, UV. So sunburn, that's a type of inflammation. It could be the chemicals we're using in the labs. And tissue necrosis. The cellular products of tissue necrosis do actually trigger inflammation. Obviously, inflammation is the response of living tissue, and necrotic tissue is dead tissue. So the inflammation occurs around the necrosis. Difference here is apoptosis is regulated cellular death, programmable cell death. That doesn't trigger inflammation. So there are two main types. We've got chronic and acute, and depending on the persistence of the injury, maybe it's something that can be mopped up quickly, maybe it will go on a bit longer. Clinical symptoms are an indication of this, as is the causative agent. So we'll go on with causative agents and the resulting chronic inflammation a little bit later. And also the nature of the inflammatory response. The chronic to acute or acute to chronic is, they say you can draw a line, but it's somewhat arbitrary in as much as it is a continuum. So it doesn't suddenly, at 2 days of inflammation, become chronic. It's what cells are involved and what histopath features you're starting to see. So, acute inflammation, it's defined as an early or a rapid inflammatory response to an injurious agent. And it's characterized mainly by neutrophils or polymorphs, depending on which term you prefer, and later by macrophages. So neutrophils are phagocytic in nature, and they're also termed granular cells because their cytoplasm contains granules that contain enzymes that can help bust up the offending agents. They have a relatively short shelf life, so they can get in, do their thing, they die off. And if more inflammatory mediators are required, then you send in another wave of neutrophils, right? Macrophages are our big eaters, essentially, and they stick around a bit longer. Okay, so there are three major and interrelated components of acute inflammation. The first is vascular dilation. So we get an agent that penetrates the body. We'll go with the bacteria for this sake, and it's recognized by a macrophage. The macrophage then sets out a bunch of cytokines. These might be histamine, serotonin, and even nitrous oxide. The result of this is vascular dilation. So the blood vessels around the site dilate, and as I've said previously, that actually slows the blood flow through the area and increases the vascular permeability. We then get endothelial activation. So with the increased endothelial permeability, the endothelial tight junctions actually open up a little bit, and this allows some fluid under hydrostatic pressure to move out of the blood and into the stromal tissue. So this might be protein rich, it might be rich in fibrin, all of those proteins that are going to assist with the inflammatory response. So this is where we see our edema coming into play. Now you've got to remember that there is a lymphatic system on the other side of this that's going to mop up all of those excess fluids. So it's not like your finger's going to blow up like a balloon. There is a regulatory process in place. We also see, as part of this endothelial activation, is the expression of adhesion molecules. So as the neutrophils start to migrate to this area, they need somewhere that they can anchor, and these endothelial cells start to express those anchor points. We then see neutrophil activation, migration, and extravasation. So basically what we see here is an expression of, it's cluster of differentiation 63, I think, CD63 on the neutrophil cell, and this will actually couple with those anchor points in the endothelial cell. So the neutrophils come in the blood, they anchor to these binding sites, they start to roll along the endothelial, the interior endothelial cell wall, and then slow down, stop, and then can actually push through the endothelial cells out into the stroma. Give me strength. Just leave it, Sam. It'll be fine. Migration. I think I've covered all of that already, actually. Diabetes, this is something that I think we covered in basic cell. No? Okay, so it's basically the same thing, extravasation. So it's the ability of these cells to become motile within the stroma. So they squeeze through these junctions and into the stromal tissue, and they actually migrate along a chemotaxic gradient that's produced by those satellite cells, the macrophages and the like, that will actually draw them into the site of injury. And there they can begin their phagocytic or protease removal of the pathogen. There are two terms that I would like to picture there. Yeah. Two terms that I would like you guys to be familiar with. One is chemotaxis. So this is basically a chemical gradient that facilitates the migration of the neutrophils. They're soluble chemicals. Obviously that's important because they've got to be free in the blood plasma to be picked up by the leukocytes, and they're factors that are secreted by host cells. So they might be either damage-associated protein molecules or pathogen-associated protein molecules, but essentially it's something that is foreign to the body in a state of equilibrium if it's damage, or if it's pathogen, it's foreign to the body full stop. So these are your antibodies essentially that we're talking about. And diabetes, as we've said, is the passage of blood cells through intact vessel walls. So you're going to need to think about diabetes separate to ulceration. Ulceration, we see blood vessels leaking freely onto a stromal surface or an epithelial surface through the destruction of the walls of those blood cells, those blood vessels. But in this instance, the blood vessels remain intact. It's a normal process. That's the picture I'm after. So we've got activation of the neutrophils. L-selectins start to express. We also get expression of the adhesion molecules on the endothelial cell walls. This grabs a hold of the neutrophils, bearing in mind that this blood vessel has dilated. Then this neutrophil starts to roll. It adheres more firmly to the endothelial cell wall and stops its migration. The chemotaxic gradient is strongest here, so it actually slips through the endothelial gaps and migrates to the site of injury. That's it in a nutshell. I don't expect you guys really to remember these. I more put them in because they're going to come up time and time again as we talk about cellular destruction. So we've got our vascular amines, so this is our histamines and serotonins, and basically these trigger vascular permeability and dilation. Our cytokines are our master regulatory pathway molecules essentially, and as I said, they're soluble proteins secreted both by immune cells and parenchymal cells. So this is important, particularly in the liver, and we'll look at liver fibrosis in the next set of lectures that we do. And yeah, hepatocytes and satellite hepatic cells in the parenchyma actually can secrete these cytokines as well. They're either upregulatory or downregulatory, in as much as it's all a cycle, so you would have checks and balances in place. The ones that we see most commonly are TTFN alpha, or tissue necrosis factor alpha, and interleukin 1, and these are the ones that are secreted by both. So they promote immune cell extravasation and activation of endothelial cell expression of adhesion molecules, as we've said. So this hopefully just sort of wraps up nicely what we just talked about and has given you some names to those cytokines. So we've talked about acute inflammation. We throw a whole lot of neutrophils at the area. They migrate to the site of injury through the blood vessel walls and out into the tissue. The outcome, most favourable outcome obviously, is resolution. So we get clearance of whatever the assaulting agent is, and then we get restoration of both the cell type that was there and the architecture that was there. So we restore to normal function. This will occur when the injury is transient and cellular damage is minimal. So there are some cells that can regenerate, neurons being one that doesn't. But yeah, for most, like on the skin, for instance, and that sort of thing, any sort of cut, you don't end up with a whopping great scar. The skin does have capability to regenerate, providing the injury is minimal. A less favourable outcome is abscess formation. So this is when the source of the injury is concentrated and it's intense. So there'll be a large number of neutrophils involved, and basically you see this often in chronic inflammation as well. So in chronic inflammation, which we'll discuss shortly, you bring in your hard hitters. Basically, these are cells that nuke the site. They're not specific between foreign and host. They just wipe it all out. So what you start to see here is a build-up of enzymes that can degenerate the cells, triggering either apoptosis or necrosis. And obviously, if you get necrosis taking place, you've set up a positive loop there, because more necrosis, more inflammation response. And you end up with an abscess. So this is an abscess in the stomach lining. You can see here, this is muscularis mucosa cutting through here. I'll use the mouse so that people at home watching know what's going on. This is your muscularis mucosa. So here you've got your lamina propria and your epithelium in those gastric pits. So what we've seen here is a build-up of inflammatory cells to the point where it's actually eaten away that entire epithelium. It's eaten away the lamina propria, it's eaten away the muscularis mucosa, and it's actually down to the muscularis externa, so that's the muscle wall of the stomach. We'll go into what can cause this next week with some of our case studies, but essentially you can imagine we've got here what's called a slough, which is just a collection of debris, dead cells, blood vessels that are leaking out now into the stomach. Every time this person eats and gets a build-up of gastric juices, this is going to burn like buggery. So, but we do see ulcers elsewhere. Basically, yeah, it's any extravasation, removal of an epithelial surface caused by chronic inflammation. And this is another outcome. So, not all abscesses result from chronic inflammation, and not all chronic inflammation results in abscess formation. But essentially, if acute inflammation, if neutrophils are unable to deal with the offending pathogen, then we've got another arsenal we can bring in. In this slide we've got a scenario where an inflammation lasts longer than several days is termed chronic, but really you're looking at the cellular involvement. So you've got a prolonged duration for chronic inflammation, and it's characterised by mononuclear cell involvement. So you've got macrophages, lymphocytes and plasma cells. So with your lymphocytes you're thinking your active killer cells, your T cells, your B cells, your macrophages, your phagocytes as well. But we see tissue destruction here, and commonly repair will not be through regeneration, it will be through fibrosis. So regeneration is where we see restoration to normal cellular phenotype and architecture, and therefore normal function. When we've got repair through fibrosis, basically we're using putty, wall filler, to chog up that site of injury. We can subdivide chronic inflammation into non-specific chronic inflammation. So this arises from non-resolution of acute inflammation, so our peptic ulcers or our abscess formation. Specific or primary chronic inflammation arises from a response to an agent like rheumatoid arthritis or idiopathic pulmonary fibrosis. So in this instance you've got a specific agent that's causing an issue rather than just a deregulated inflammatory response. Granulomatous inflammation is a subset of specific chronic, but it's characterised by the presence of granulomas. Example of this would be tuberculosis. We do talk about okay. So this is what we're looking at with chronic inflammation. So we've got inflammatory cells in the lung parenchyma. We actually have a bit of metaplasia going on in as much as the simple squamous epithelium has been replaced with simple cuboidal. But really the take home from this is the amount of fluid, inflammatory cells and destruction of normal lung parenchyma. So you can imagine that when this resolves, if this resolves, we're going to have a replacement of normal lung parenchyma with scar tissue. Alright, granulomas. So you can imagine you've got an offending agent, and I'll use one that we see commonly in the lab, is buckshot. So a lot of farmers out there not so good with their gun safety, and the doctor will cut out a bit of skin and say, oh, there's a dark lesion in the dermis, it might be a melanoma, and we'll be cutting into it on the microtome and something, doing, Jesus, what was that? And you look in and there's some shiny metal object staring back at you, and then you contact the doctor, oh yeah, his brother shot him in the leg about 3 years ago. So obviously this is the buckshot is foreign to the body, so it does stimulate an immune response. You can throw all the neutrophils, the natural killer cells you want at it, it's not going to dissolve the lead, right? So this is the body's response to that. Rather than trying to remove the pathogen, basically it walls it off. So if you think of that spare room you've got at home with all your camping shit in it, and you close the door and forget it's there, this is kind of what the body does. So you get a build-up of macrophages and lymphocytes around the site, and then it just deposits fibrin all around the offending agent. And so the lymphocytes and the macrophages basically act as satellites to make sure whatever is encapsulated in there isn't breaching its borders. And sometimes the macrophages actually fuse together. So this is one cell, but it's basically a whole bunch of macrophages that are fused to form a giant cell. And sometimes they get up to like 100 nuclei in a single cell. You do often see central necrosis within granulation tissue if the offending agent is something like tuberculosis, for instance, or if it's, say, a splinter that can't be removed. Because of the initial inflammatory response, there's cellular debris that gets walled into that granulation tissue, and so that can become quite unpleasant. And then obviously if you do have necrotic tissue with an infection, then things can start to grow a little bit out of hand there. So there are two types of granulomas. One is a foreign body granuloma, which, as the name suggests, it's something that shouldn't be there. So your suture that's been left in, even though they assured you that it would dissolve over time, and it didn't. But basically it's an inert foreign body, fibres, etc. You can often identify these in the middle of the granuloma as well. So I've seen a few sutures come out of patients encased in a granuloma, and as you're slicing through it, you start to see this shiny refractile object, and then when you stain it up, sure enough, there's a suture there. Immune granulomas, so these are caused by a variety of agents like TB, as we discussed. Have you guys talked much about TB in the past? So it's a bacterium that divides very slowly, so it doesn't trigger a full-blown immune response straight away, but it's also got a special coating on the wall that makes it immune to most of our responses, so it's very difficult to remove. We will look at that later on. Just glancing at this slide, I see we've got COPD written on it. That will make Romy happy. So, acute inflammation. We're talking about histopathological changes. Excuse me, at this point. So, as I said, we get the arterial beds start to dilate, as do the capillary beds. And this results in increased vascular permeability. I know I'm sounding a bit repetitive here, but it's basically the building blocks of inflammation. Now we're looking at what we see under the microscope. We do see increase in albumin staining in COPD, but this isn't limited to COPD. You do see that in most inflammation, and you'll see it just as sort of like a pink, watery material on the slide. We also see the migration of neutrophils, and this is something that we can actually see under the microscope. So here we've got early acute, and you can actually see those neutrophils lining up along the blood vessel walls, ready to start migration. And here they are moving out into the inflamed stroma, and later on that same day we're starting to see deposits of fibrin, etc. So in the exudate, so this is what is removed or what moves out of the blood vessel, we've got fluid, fibrin, many neutrophils, some macrophages, and a few lymphocytes. They're all derived from the blood. This is what we see. So these are what neutrophils look like, the polymorphs. How far through hematology are you guys? Hematology 2. Heme 2? No heme. Rightio. This is what a neutrophil looks like. So it's a paler staining, and you guys can correct me on this because you've done heme more recent than me, but basically a pale pink staining cytoplasm with, it's termed a polymorph because it's got multiple lobes of the nucleus. Does that sound fair? Yep. Macrophage, they're these big buggers, so they've got very large but less intensely staining nuclei and quite large cytoplasms as well. And then fibrin should be quite familiar to you guys from last semester, collagen deposits, essentially. I'm not doing anything. Right. Cool. So what we're looking at here is pneumonia, and those of you that were in the prac last week, this should be familiar to you as lung tissue. But what you can see here is all of the air sacs are filled with this amorphic pink material, that's your fibrin, and then you've got a massive inflammatory response with the polymorphs there within the air spaces as well. So you can imagine what it would be like trying to breathe through this. This is later on that same day. So it's starting to resolve. We're seeing less neutrophils, more macrophages as they come in and sort of mop up the mess, and we're starting to see a bit of clearing of the airways as well, but not a lot. Remember too that a lot of this fluid would be cleared through the lymphatics. Cool, so now we're going to look at chronic inflammation and the histopathological changes. So, as I've said previously, predominantly the cells present are your macrophages, your lymphocytes, and your plasma cells. I don't expect you to be able to differentiate a plasma cell from a lymphocyte at this point in time. That's fine. But it's a mononuclear cell predominantly that's there. We do see some neutrophils there, and it is possible to have a site or an area of injury that is so large that you'll have an area of acute inflammation, and then further back you'll have chronic, particularly if it's an injury that's moving through the tissue. So don't get too hung up on, is it acute, is it chronic? Do you see acute cells, do you see chronic cells? If you see both, put both. Eosinophils you might see, these are very vibrant red cells. Generally they're bilobed with, I'm glad I remembered, with very big, vibrant, pinky red granules inside. And they're often associated with parasitic infections. So this is what we see. So this is an eosinophil. Here's another one down here. You can see the bilobed nucleus. We've got our fibrin, leukocyte, and plasma cells. So plasma cells have got slightly larger cytoplasms and slightly paler staining nuclei than the leukocytes, but whatevs. And then we've got our fibrin throughout. So this might look quite similar to the other image that we saw previously, but if you put them side by side, you'll see just how different the polymorphs, the neutrophils, are. That's helpful. Should have had that a few slides ago. So this is our polymorph, our neutrophil, and you can see it's multilobulated nucleus. Eosinophil with our red granular cytoplasm, bilobed. Basophil, you don't often see them in tissue, really ever, but that's what they look like. Monocytes, these can, once they're out into the tissue, they're termed macrophages, and they get quite large. There are big mop-up crew, and our plasma cells from our lymphocytes. All right, so cells of inflammation. So we're looking at acute inflammation here. This is a good opportunity to compare and contrast. So we've got some neutrophils, yep, and this would be the appearance. I know the arrow is pointing to it, but it should be pointing at that one. This is the appearance more of a lymphocyte. It's just a single nucleus, very densely staining with very little cytoplasm. Obviously this is our endothelial layer, and our neutrophils are migrating out into the tissue. An artist's rendering. Macrophage, so we're now moving on to chronic or late stage acute, and they've got these much larger, paler staining cytoplasms and often fragmented in appearance nucleus. And the foreign body giant cells are here. You'll get to see them. They're often much larger than that, but you've got at least 7 nuclei in that single cell. I can count 5 in that one. They're not a nice round cell shape that we're often used to seeing. They often send out these little feet to try and feel around for things. And our lymphocyte, so comparing that to give you all whiplash. Keep that image in your mind, right? There we go. So you've basically just got a nucleus with virtually no cytoplasm. So these are our lymphocytes, these are our chronic inflammatory cells. And our plasma cells, so again, very similar to the lymphocytes, but often a larger cytoplasm with a paler staining nucleus. So our routine stain, H&E, is what you've just looked at for all of those, and it's what you'll look at in the lab. Very rarely do we stain IHC profile on inflammation. It's just not warranted. Oh, we've lost one. Do you want to just tap him on the shoulder? That's all right. Make sure he's still alive. There we go. Yeah, we very rarely do profiling on inflammatory cells. If we did want to, we could use the cluster of differentiation to figure out what we're looking at. But basically, you've got an inflammatory response. The pathologist wants to know, is it acute, is it chronic, what's causing it, and how do we go about fixing it. So the number of CDs for humans is up to 371 at the minute, so you can imagine based on that, you can use IHC to get an accurate ID on a cell. But as I said, who can be bothered, really? Having said all of that, the CD markers for the cells I've listed there, CD45, so common leukocyte antigen, CD45 is common to almost all cells found in the blood, and that's what we'll be staining for today. So you will have a gallbladder undergoing potentially an inflammatory response. I've given you the H&E, which is already in your slide box, and you can wait till next week to look at that if you want, but you'll be staining for CD45. So everything that comes up brown, assuming you do this correctly, will be an inflammatory cell. If it's not in the circulation. If it's in the circulation, then it's in the blood and we wouldn't turn that an inflammatory cell. But if it's in the stroma, then it's migrated to that for some reason. So it'd be an inflammatory cell. So I'm hoping what you'll do is you will have your two slides next week side by side, one IHC, positive for CD41, one H&E, and you'll find a cell and you'll go, oh, okay, that looks like a really dense cell under IHC. You look at it under H&E and you're like, oh yeah, that looks like a lymphocyte. So hopefully that will give you an opportunity to start IDing inflammatory cells. So basically what I want you guys to take away from this lecture is the pathway from point of infection or penetration or injury through to resolution. Next week we're going to go through some case studies, and I appreciate we haven't gone into much detail on fibrosis. That's a whole lecture all on its own. So just be aware, we haven't quite left this topic alone, but if you can wrap your heads around in detail the pathway of inflammation and the cells involved, you're going to be set. So you know where we're headed. Next week we'll be looking at images. It's frozen on me now. That's great, isn't it? Looking at images like this. And if you can recognize inflammatory cells, you're golden. You only need to know what the tissue type was originally, right? So that's sort of where we're headed. So spend a bit of time in the lab today or over the next week. Just bring yourself up to speed with those cell types and those pathways involved. There's no tute for this week. We'll have a tute next week that will encompass both of these, this week and next week's lectures.